Thank you. Thank you, Jenny, and thank you to Myeloma Crowd for having me um, present today. Um, so I agree with you completely. You know, Ashraf was shortchanging himself. Not true. I think the important thing to know is there's lots of treatment options for patients with myeloma, and that's really critical. And over the course of your diseases, I do think you're going to need to access all of these different options. And hopefully in the panel discussion, we'll have more of that. What I am going to talk to you about today is I've been asked to cover sort of a range of different things, talk about advances in supportive care, talk about impact of approval of CAR T cells, and we'll finally talk about COVID and vaccinations with COVID as well. So I'll start out with supportive care and specifically talk about bone disease, because as you all know, I think the importance of bone disease in myeloma cannot be underscored. And I would argue and say that bone disease impacts nearly 100% of myeloma patients. We know that it's because of an imbalance in bone formation and resorption. And over the years, we really tried to understand what the interactions of the bone forming cells and the bone resorping cells are. And specifically, we figured out what the proteins are. And most recently, I think we've highlighted the importance of rank ligand. So before we talk about certain drugs to rank ligand, I do want to mention imaging with bone disease and myeloma. And, you know, in the old days, we all did x-rays. You're all familiar with the skeletal survey, but this has now been replaced with using a whole body low dose CAT scan. So the majority of patients should be getting this as opposed to the skeletal survey. And for the simple reason, on a skeletal survey, you're able to pick up bone disease in about 60% or so of patients. You need a significant amount of bone loss before you can pick this up on x-rays, whereas a myeloma bone CT survey is able to pick up disease in more than 90% of patients. We're going to talk a little bit about where PET scans can be used as well as MRIs. These are specific situations, and talking to your myeloma doctor is going to allow you to figure out where and when these other options should be undertaken. And so much so that the International Myeloma Working Group has now come up with use of these different screening modalities even in assessing responses. And the reason for that is just highlighting and underscoring the advances we've made in our patients with myeloma. Adam earlier on with the CAR T cells talked about minimal residual disease in patients with myeloma. Well, we're using imaging also to document minimal residual disease in patients with myeloma. So I don't want you to go into the details of all of this, but sufficely to say that we are not only getting better at treating patients, but we are also getting better at monitoring patients. And there may be situations where you will require a whole body functional MRI or a PET imaging modality as well. All right, so you know what I was talking about is imaging, so make sure you'll get the proper imaging done for your bone disease. And then moving on to newer drugs for bone disease, we've shown denosumab. Denosumab is a rank ligand inhibitor. It's a monoclonal antibody, and we've done a very large study comparing zoledronic acid or Zometa, which all of you are familiar with denosumab. And what we've shown in this large study is the fact that whether you use denosumab or zoledronic acid, the rate of skeletal-related events is equivalent in both. But interestingly, what we found was an improvement in progression-free survival of patients who got denosumab. It sort of underscores the fact that this antibody might have some anti-myeloma effect as well. I think other very important things, and those of you who have myeloma, I cannot underscore the importance of making sure that your kidney function stays normal. What we did show in this study was the fact that denosumab seems to be a little more gentle on the kidneys, so the kidney toxicities are a lot less compared to other drugs with myeloma. So we do have new International Myeloma Working Group guidelines. You can either use zoledronic acid or denosumab. And for those people who have sort of borderline kidney function, I would argue and say, make sure you're on denosumab as opposed to zoledronic acid, as it's gentler on the kidneys. There's a couple of things which people need to follow through on. We've talked about dental issues when it comes to all of these drugs. So make sure you see your dentist, and calcium and vitamin D supplementation is really important, whether you're on zoledronic acid, permethrin, or denosumab. I am going to spend a little bit of time now on talking about CAR T cells. Adam has made my job very easy because he did talk about the KARMA trial, but I'm just going to repeat a few things here, and I'm going to focus mostly on BB2121 or idacaptogene baiclucil, ide-cel. This, as Adam has shown you earlier on, is a CAR T cell product which recognizes BCMA, that's the B cell maturation antigen, which is present on the majority of myeloma patients. And then it has an intracellular domain of 41BB, which activates the T cells so that they proliferate, as well as CD3 zeta. And what we have in our first in human study was when we went to 150 million cells or so, we saw that patients actually had a response, and the median progression-free survival of these patients was close to a year. And if you achieved an MRD negative status, those patients had a median PFS of close to 17 months. Now, this then led to the KARMA trial. Adam has already gone through this, so I'm going to go through this very quickly. These patients, 128 patients were treated, and as Adam had pointed out, these were very heavily pretreated. When I mean very heavily pretreated, had seen an IMiD, both IMiDs in fact, both proteasome inhibitors, and had also seen a CD38 monoclonal antibody, and the majority of patients were refractory to all of these classes of drugs. As is shown you already, once you get to the target dose, the response rate was in excess of 80%, with close to 40% of patients actually achieving a complete response or a stringent complete response. This translating into a median progression-free survival and overall survival of 9 months and close to 20 months. If you look at the PFS by dose and by response, once you achieve a stringent CR or a CR, the duration of response was close to 20 months. So underscoring the fact that achieving a good response to these cellular therapy approaches is really critical in the success of these products. There's a bunch of products, and again, Adam has gone through all of these. We have idacaptogene baiclucil or ide-cel that I've just shown you data on. There's another product called Orvacel or orvacaptogene autoleucel, and Adam showed you data with cilta-cel as well, which is a product from J&J. All of these have been used in very heavily pretreated patients, and certainly he's talked about the toxicities associated with this, but I will tell you that although we see CRS, although we see neurotoxicity, most of that is manageable in more than 90% of patients. So generally extremely well-tolerated approach. And if you look at the response rates again, all of these products have a response rate in excess of 70%. The longest follow-up is that with ide-cel. We're waiting on longer follow-up with cilta-cel as well as Orvacel. So will the approval of CAR T cells be a game changer? I do think it's going to offer us the potential of high response rates in patients with myeloma. And the question really is, because we have all of these different drug products, which CAR for which patient? I don't think we have a good answer for that. The good news, though, is we have choices. And finally, obviously, we can talk about this during our panel discussion as well. Can we do better? And the answer to that is absolutely yes. There's already ongoing trials, and we can address some of them during the panel discussion. Finally, I'm going to talk to you about COVID-19 and myeloma, because obviously this is on everybody's mind. You all know what SARS-CoV-2 is, and I'm not going to spend time on this. You also know what the common symptoms associated with COVID-19 illness are. There's obviously a few things which we don't completely understand, wherein you get other organ involvement like the heart, the kidneys, and so on and so forth. But in general, I think over the last year, we've all been in some way impacted by COVID-19. This is the status of COVID-19 in the United States as of a couple of days back. We have more than 25 million cases with more than 430,000 deaths from COVID-19. And these are the numbers just from Jan 28. So 165,000 patients were diagnosed with close to 4,000 patients dead from COVID-19. So this is not going away anytime soon, and it's really critically important for us to see what we can do to keep all of you safe and all of us safe from COVID-19 going forward. So the big question is, do cancer patients with COVID-19 do worse? And certainly if you look at the data and if you see patients, not just cancer survivors, but patients with active disease do have a worse outcome, and therefore it's really important to protect yourselves from COVID-19. We've specifically looked at plasma cell disorders and COVID-19 as well. And again, this was early data when the pandemic just started off. And that's why you see differences in different countries and outcomes. That's largely because of how the pandemic spread. But I think going forward, we have identified certain risk factors in patients with myeloma, such as age, high-risk disease, other comorbidities, and renal disease will have a negative impact if you end up with COVID-19. So the best thing one can do with COVID-19 is prevent from getting COVID-19. Now, management of patients with myeloma in the era of COVID-19, there's a whole lot of bodies which are looking into this, specifically the International Myeloma Society, ASH, etc. I think the key is patient education. There has to be an individualized approach. We've all started using telemedicine in our the way we take care of patients. And as far as treatments, I think the biggest thing that I'm going to leave you with is it's really important to keep your disease under a good control. That's going to have the best outcome when it comes to COVID-19. So the IMS has a few recommendations. And currently, really, I think the biggest thing to remember is there is no data to support avoiding specific drug classes. So whatever you need for your myeloma control should be used. Certainly, if an oral drug is something which is working for you, that's fine. And doing that should not be an issue as well. Talking about vaccines now, there are different COVID-19 vaccines out here. What we will be focusing on is the mRNA vaccines or the viral vector vaccines, because those are the ones which are approved. Certainly live attenuated vaccines, although they are being tested, will not be used in oncology patients, certainly not in our myeloma patients. So these are the COVID vaccine trials in phase 3 trials. This is the Pfizer vaccine BNT162b1. You know that this has gotten FDA approval, and this is an mRNA-based vaccine with a 96% immune response rate. Then you have the Moderna vaccine, which is also an mRNA-based vaccine, and this has again gotten FDA approval, again an mRNA vaccine. So either of these two vaccines are in use as we speak. The only difference between both of them is if you get the Pfizer vaccine, the second dose has to be given 3 weeks later. With the Moderna vaccine, it's about 4 weeks or so. The third one, which I do think we should talk about, is the J&J vaccine. This, you just heard 2 days back that the phase 3 trial has shown an immune response rate of 66%. Now, although this looks like it is inferior to your Pfizer or the Moderna vaccine, I'm going to argue and tell you this is just a one-shot vaccine. Remember, when you got the Pfizer or the Moderna vaccines, these these vaccines had an immediate one-dose response of about 30% or so. So this vaccine is quite good. It can be refrigerated, and the argument should be, if a vaccine is available, whichever one is available, I think taking that vaccine is going to be critical going forward. So I think the key points here is the risk of infection, COVID-19 infection, not necessarily higher in myeloma patients, but if you end up getting COVID-19, the risk of severe infection can be worse, specifically depending on where you are with your immune compromised state. I think the most relevant complicating factors are uncontrolled disease and comorbidities. That's why I cannot underscore the importance of, if you have active myeloma, do not refrain from taking treatment. You should be getting treatment, and you should be getting whatever is best available for your specific myeloma. I do think, even after vaccination, it is really important that we continue to mask up, we continue to social distance, and we continue to try and reduce the exposure, specifically when we are seeing COVID-19 variants as well. Vaccines appear safe and they should be used, and both the mRNA vaccines as well as the viral vector vaccine, which is a DNA-based vaccine, can be used in the context of myeloma once it becomes available. So absolutely say yes to vaccination and try and get yourself immunized. With that, I thank you for your attention, and I look forward to the panel discussion. Thank you.